come along and talk today about the diagnostic testing and what is going on in the world of genetics in general. I was really excited because we are trying to do so many things, and I was just talking to Catherine. I was telling her I was talking to someone last year about how the work for finding new treatments and cures for different conditions is going on. And what has happened in the last 20 years is truly exciting, because the technology is ahead of us and now we are literally playing catch up. There is so much going on and there is so much we can do that we are trying to now bring this into the clinical world and actually try and help the people who want to find these different cures and sort of get this into clinical practice. So what I want to do today is, and I will try not to be so technical when I am speaking about the different methods we use in the lab, but try and sort of bring this out that there are many genes now known for the different type of muscular conditions. And I want to show you that how the costs have decreased over time, and it's truly surprising for me. I started doing my work in the field of muscular dystrophies in 1992. And the cost of doing the clinical testing has dropped tremendously since then. It's truly shocking for us even in the lab that we can do so much more now. And all of us read different things in the media nowadays, and I hope all of you have sort of heard these terms about sequencing the entire human genome, and now we can find so many things, and I'm going to show you some work on that as well. So this is just a very simple slide. It just tells you how many genes are there in the human genome. In all of us, there are about 22,000 genes. But today, we only know that there are about 4,600 genes which are associated with some sort of a clinical condition. So that is telling us that there is so much more to do right now, that there is so much, we just don't know what is there in the human genome. The Human Genome Project was completed, that is, we know every base, every piece of the human genome, and that was done 10 years ago, and it took about $2.7 billion to complete the sequencing. And now we are really into the next phase. The idea here is that we want to know what these 22,000 genes actually do in our body. We can improve diagnostic testing. And as Catherine just mentioned, biomarker discovery is a big area that is growing very fast, and now get into clinical trials and find different therapies which can help the patients. So in general, when I am talking of genomic tests, we are really talking about diagnostic testing, and this is for either inherited conditions or somatic conditions, and by somatic essentially it means cancer type conditions. There is another big area that is moving very fast in the field now, which is called carrier testing. That all of us are carriers of 2 or 3 mutations in different genes, and now we can find out what we are carriers for. Now this information is good for us, it's good for our families, and that can be sort of taken into our medical records, and there are many new things that are happening. One of the things, exciting things that is happening is that the NIH last year sponsored a project for newborn screening, that is to take the blood of a newborn and sequence the entire genome of the newborn. And this is like having put this data into a bank, and then let's say the baby has got a cold and is not responding to a particular drug. So you go back and pull that piece of information, check it, why the baby is not responding, and change the therapy. Now obviously this is very expensive right now, but if you can imagine a situation 100 years from now, maybe this is going to be completely feasible that we can do this so that people don't wait for treatments and all this data is already banked and you just go to it when you want. And the last area which is also moving very fast is called the pharmacogenetic markers, is how we all respond to drugs. Not all of us respond to the same drug in the same fashion. It's all a difference because we are all different, a little bit different here and there, and that's the other area which is growing very fast. So if you just look at what is the complexity, because how do we do the testing in the lab, how can we find a mutation in one gene? And in about 1980, so we started with knowing that one clinical condition is always associated with one gene. And slowly that concept has started changing. I have sort of listed different disorders here with a number of genes, and you can see now, if you look at just straight go to 2010, you can see that how many genes are there per condition. Now, this immediately brings to your mind that how do we know what condition it is? You really need to know what type it is so that you can get the proper treatment that is needed. So, just moving on from different conditions now to just focus on the neuromuscular conditions. And here I have just listed all the different genes that have been found in the last 10 years, and you can see how many genes have been found very rapidly, and all the different overlap that is there between the different conditions. This gets very complex, not just for the physician but also for us in the lab when a sample comes for testing, because what I have to report back is not only just what type it is, but what are the mutations that are there in that gene, where they lie, so that that can guide treatment eventually. So now not just looking at the different genes, but if you just take one gene and look at what are the different clinical phenotypes, you can see there is a range of phenotypes you can see, with an extremely severe phenotype to a much milder phenotype. So again, this could depend on what changes happened in the DNA of that gene so that we can report accurately. So the problem here is, we know there are many genes. How can you test for these hundreds and hundreds of genes at one time in a very cost effective way, so that everyone can first afford to get tested, but also that report can go back to the physician and it can be utilized to actually to create a treatment plan. So this slide is actually not a good slide. I don't like it, but I took it from a paper and I cannot change the color. It's very hard to see that slide. But the idea here is to just say that when you say that there is a mutation in a gene, it essentially means that there are different types of mutations. So you can see here that you can see this whole range of different things. It essentially is just saying that a gene can contain just one letter missing, or there could be hundreds of letters missing from that gene, and not one method can actually pick up everything. So that essentially means that in the lab we have to try different things to make sure that we have tested for everything and we have not missed anything. So if you just look at, this is just like a picture diagram of a gene. What EX1, EX2, EX3 means is just a part of a gene. So if you look at EX2 and you see that little arrow, that means a letter is missing at that point, and that's the possible DNA change which has led to the condition. Or if you look at EX3, you will see that cross there, that means that that entire EX3 is just completely gone. There is not one method right now which can pick up all these different types of changes. So it also means that in the lab when we are doing testing, we have to use these different methods so that we can do comprehensive testing and not just detect one type of mutation. So this is the old method which we call Sanger sequencing. This method was discovered about 20 years ago and has been used by most labs for the past 10 to 15 years. And the idea here is that you want to look at each piece of the gene one by one, and that's what we do, and then we get a readout like this where we actually manually read each letter of the DNA with sitting in front of a computer screen and actually try to find out which letter got changed in the individual leading to the condition. This was extremely laborious work. It is not something that can happen in one day, 1 week. It used to take months to do this. But now this new technology which came out about 7 years ago, and now it is routinely used by many diagnostic labs, and we call it next generation sequencing. We had to come up with a name. We went from, Sanger was the name of an individual, but now we are in the new generation, so it's a next generation sequencing. Essentially what happens is that instead of looking at one piece of the gene at one time, we take all the pieces of the human genome. You can see each red is one gene, green is one gene, black is one gene. We basically just take the entire DNA we get from the blood sample of the patient and chew it up, and then one by one we actually start looking at each gene in this machine. And this machine literally is like this. This is a glass slide, and this glass slide has got 8 channels, and that little circle which you see there, this one is just a point in time where the laser is looking at this piece on the slide and projecting it out and actually doing a digital readout like this. So if you remember, I said earlier that we were looking at this digital readout one by one. This has now translated to this for us. It is just letters. It's making it a lot easier for the eyes because we are not trying to recognize color. We are not trying to see which letter is actually missing. There are computer programs now which automatically tell us that such and such a letter is missing. So this has given us the ability to look at hundreds and hundreds of genes at one time. And we can now create something which is called gene panels. Now this is a very technical slide, but what I am trying to show you here is, if you remember, I said that each gene has different kinds of changes and not one technology can pick up everything. And this is the problem which we have with next generation sequencing. There are many genes in our genome which have similar readouts somewhere else in the genome, and it can create confusion when we are reading. So we don't know we are actually reading the gene we are supposed to be reading, or this pseudo sequence we call it, which is somewhere else in the genome. So that's number one, because next gen sequencing, remember, is just chewing everything up and it's just reading it. It is not telling me whether I'm reading the right thing or not. So any region which is a duplicate in the genome cannot be done by this method. Any region which is completely missing, you don't know what is missing because you don't know you actually missed it. Next gen sequencing cannot do it. There are regions in our genome which are just complete repeat of letters. And there is an enzyme that is used in this technology which has to go through one letter at a time and it gets confused. So let's say it's trying to read the letter G, and the moment it starts saying G, 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 it cannot understand it. It starts slipping. So these are the type of DNA changes we just cannot understand using this technology. But it's a huge improvement over doing gene by gene by gene. So this is what has happened. We can now sequence all known genes with the neuromuscular conditions for less than the price of doing sequencing of the Duchenne gene. And the reason I use this Duchenne gene as an example is because it is the largest gene in the human genome, and it used to cost, when I started doing my PhD, at that time it was about $10,000, and now it has come down to under $100. So you can only imagine what is happening. It is continuing to decrease. I had a grant from the Muscular Dystrophy Association to develop newborn screening for Duchenne muscular dystrophy. And now you can only imagine, if you are going to do this test on every newborn, it has to be really, really cheap. And the aim now is to take it under $20. And I think we are getting there. The last pricing I did was about $42. So we are now, slowly going in that direction. This is very exciting. The difficult part of this is that how insurance companies and how institutions will actually pay the lab which is doing the testing. And I think that is where we are getting stuck, but I'm really hoping that this could change significantly. One thing which I want to point out from this slide is that you see this second bullet here, which is the incidental findings. What has happened as a consequence of our ability to look at the entire genome is not that we can just look for the gene in which we suspect the patient has a mutation, but these are the findings which you are not looking for, and we call them incidental findings. Now, in the scientific field, people have problem with this word, okay, because it is not an incidental finding. Remember, as I said before, we are all carriers of something. We just don't know what. And it's not a thing that just occurred during the test. We are just uncovering it. It is already there in all of our DNA samples. Now, this really is a personal decision. When we go for testing, whether we say, I want to know what else is there in my DNA sample, or I don't want to know. And people make different choices. It's a personal choice people make. If I can tell you, of all the samples we test, about 95% or more people want to know everything we can find. But there are some people who just don't want to know anything more than what we are supposed to do is a diagnostic test. There's a huge debate in the field for that. The American College of Medical Genetics had released a statement last year where they created a list of 56 genes, and they said the patient does not have a choice. If you find something in this such and such a gene, you just have to give it back. That is, you force the data on the patient. And there was a big uproar against it, that you cannot force anyone to get a result of a test they did not ask for. So just recently they released a new statement now that it's a patient's choice to opt in or to opt out to get this data, and I completely support that. In our lab, even though the college had made that release last year, we have never done that. We have always kept the choice on our consent form of opt in or opt out, because I think it's a patient's right to choose what they want to get back from the lab. Now, as I said before, there are different types of changes in our genes and not everything can be picked up. Next gen sequencing, even though it's very exciting, we are doing hundreds and hundreds of genes at one time, there are still certain regions where the entire sequence is gone, it cannot detect it. So this is a slide which shows you that what we deal with in the lab is, these are some genes here where majority of the changes are just small mutations, those little arrows that on the slide which I showed you. Versus something like DMD, majority of the changes are chunks of DNA just completely missing. So how do we create a test which can detect everything? So you want to make it as comprehensive as possible and as cheap as possible. So what we do is actually we marry two technologies. We do the next gen sequencing to find the small changes in all genes at one time. Then we use this other method which is called CGH, it just stands for comparative genome hybridization. It is simply a glass slide with our entire genome just spotted on the glass slide. And using this method, you can actually find chunks of DNA that are actually missing. So now what we have done is we have taken next gen technology, we do all the genes at one time, and if negative, we can reflex it to this test. We have gone a step further now that we don't even wait for that test to come negative, because it's so cheap to do this test, we can just do everything at one time. And the idea here is not to wait too long to get the result. So one of the things which we have been able to do is take that turnaround time of the test down from 3 months, 4 months to whatever it was, to down to under a month. Now this also depends on the resources a lab has, because these instruments are a little bit more expensive right now. They range in about $1 million. So it depends on how much the lab can invest. But again, these instrument costs are also coming down very rapidly. And this is something new and exciting that is going on, that people are saying that you can sequence on a USB drive in 20 years. Literally any one of us could take it, put it on the USB drive, you sit by your computer and you're going to sequence. I don't know if that will happen, but there is a company out there in the UK which has already started trials on microbes. So infections, and they just published the first data set where they showed that they could sequence a microbe, because it's just a small amount of DNA, on a USB drive. So I have never thought in my career that I can do so many genes at one time. So maybe this is going to be entirely possible. So this is what we went from. We started with a small number of genes. We divided up the limb-girdle muscular dystrophies, the congenital muscular dystrophies in small groups of genes. And as the technology kept improving one by one, we started adding all, and I'm saying I'm decreasing with decreasing cost. So the cost to do this number of genes versus this number of genes is actually less. And then we just created this expanded panel, which is actually costing less to do than sequencing a single gene significantly. The only problem that comes when you're doing so many genes at one time is the insurance companies come back to us and say, why are you sequencing all these genes at one time? Because a clinical diagnosis says such and such a thing. Go after one gene only. and it takes a significant amount of time for our billing people to call them and tell them we are actually saving you money. We can still do one gene if you want using the old technology and charge 10 times more, but we have had insurance companies call us and insist on doing the more expensive test. And this is an uphill battle, you know, we try very, very hard in this education area where we call the companies and explain to them, but it just gets difficult when they are not understanding what we are trying to tell. So I think what is, if at all, needed in this area is actually education, so that testing is not that difficult. So the question you all will ask me is that, is there data to show that don't do single gene sequencing even when the physician has said this might be this subtype? Just look at all this. If you are saying that if you can look at all the genes at one time, is there an increasing yield? That means we are finding more mutations. And this is what I wanted to show you, that we went from a single gene test with a clinical yield of about 15%, and we started moving through doing the panel testing, and we are right at about between 60 and 70%. And as we are doing more and more genes, this is increasing. We are doing it faster and much cheaper. And this is the kind of the data that needs to get published in the literature so that insurance companies actually support this. Not just that, because through this data we are also identifying changes which can help the patients when they are going to the doctor, say, okay, I have this other clinical presentation or have this mild other difficulties, and we can find these other changes in different genes which can help support the treatment. Just as an example, we had a case where the 2 changes in the dysferlin gene were known, and then we got the sample for sequencing and we found a change in the gene called G6PD. It actually is a gene, it's an enzyme, but if you eat fava beans, you can actually get a trigger and it can cause anemia. So this is actually a patient local in Atlanta, and this person came to our clinic and had got in their medical notes that they had had hemolytic anemia. This was never known. Nobody, the physician had just made the notes, done nothing about it, but now we could tell them what not to eat so that that trigger never happens. So you can find these other things. I think it's important to understand that when you are saying yes to looking into the other, the rest of the genome, that these are the things you can find, but there are things which you may not want to know also, but again it becomes a personal choice. But we are very excited in the lab that I am not issuing reports which are kind of sometimes misleading, because if I don't tell the physician properly what I am writing and how to use that in clinical practice, that report just goes nowhere. It just gets integrated into the medical records and creates more confusion. So I think getting these kind of results, being very clear and concise in what we are presenting to the physician is going to be very important. And this is the last slide. We are very close to this place. We are actually about 10 minutes from here in the university. This building is actually going to get knocked down next year. We are moving to a new facility. But downstairs are our genetics clinics. The labs are upstairs. This is Dr. Steve Warren, the chairman of the department. He discovered the gene for Fragile X syndrome. And when I went to Emory Genetics 8 years ago, there were 15 people total in the labs, and today we are about 120 people. And it's growing very fast. We have been able, the university has been very supportive in bringing this new technology and actually investing in it. We have been, because we are a not-for-profit lab, it also means that we can help a lot more people. We do get a lot of samples from South America where people are not able to afford testing, and we do this kind of work where we can sort of balance out, because we are not for profit. If the insurance companies pays us, we can actually help a lot more patients. I'm going to hand this over to Brad, but we have done a lot of work with Jain Foundation. This has been one of the most enjoyable collaborations I have ever had in my entire career. They have given us a lot of opportunities to look into the different areas of the dysferlin gene, and I think we have had some very good publications that have come out, which have been, we recently published a paper on a method which people have been using, but not to the level of how to connect that with the genetic diagnosis. So it has been a very fruitful collaboration, and I've really enjoyed working with the people at Jain Foundation. So with that, I will stop.